Hi, welcome to Ocean Yemi's channel. So today it's about the Lucy Letby and the medical findings and how they're saying now that how she was not guilty of unaliving babies. But my thing is that it's a very dangerous thing because some of what the pathology guy, what he found, let me see if I can find what I got yesterday. Let me see if I could find the short of him saying what the babies. Is it this one? Is it the video? Oh, no. Oh, it's here. Okay. All right. Right. We'll talk about who he is in a minute. Look, we're just going to listen to some of the findings, what he found of the medical with some of the babies.
First, to review the medical records and determine the cause of death in their opinion or injury. Second, to review and comment on the expert witness statements and opinions. And third,
reviewing Lucy
provide an
Letby case.
independent report about the causes of death or injury. The methods we use, each case would be examined by two experts independently.
And one sitting with him is his lawyer, with the lawyer.
If their findings were in
See, I could find this one.
were accepted as final. If their findings differed, a third member of the panel was asked to review the case, and a consensus opinion was then developed. Summaries of each case were developed by the chair and approved by the panelists who examined the case, and then shared with the whole panel. Strict confidentiality was observed. I am the chair of the panel, and I invited members of the panel to participate on a voluntary basis and to work pro bono. Members of the panel, including myself, did not receive any benefits in cash or in kind, and even my trip here today is self-funded. The panel comprises 14 very experienced and well-known experts from highly prestigious institutions in 6 countries around the world, including Canada, United States of America, Japan, Germany, Sweden, and the United Kingdom. They include 10 neonates, 1 pediatric surgeon, 1 pediatric infectious disease specialist, 1 senior care nurse, and 1 other pediatric specialist. With the exception of myself and the member from the UK, the other members knew of the existence of the case, but otherwise had very little knowledge about it. I will give brief introductions to the members of the panel in a moment, and their biographies are in the summary reports. You can refer to it to see who they are. Okay. Now, today I will provide a summary of our findings. Copies are available at the side table, and we'll be able to access them after this
conference.
The full report will be provided to Lucy Letby's barrister later this month. Now, the panel examined all 17 cases with which Lucy Letby was charged, and they are labeled patient 1 to patient 17. The cases involve a number of different allegations about causes of death or injury, which can be roughly grouped into 6 categories. First, air embolism caused by injection of air into the intravenous system. 2, splinting of diaphragm caused by injection of air into the nasogastric
Okay, I
tube.
found it.
3,
So what they're doing now, right? They're reviewing. They said they had this new medical evidence that's come up against Lucy Letby's case. So what they're doing, they're reviewing it and telling you what is the causes that was done to the babies that she unalived or caused injury to. So that's what he's doing now.
3, dislodged nasogastric endotracheal tube causing collapse. 4, hypoglycemia caused by injection of insulin. 5, trauma to the abdomen or gastrointestinal tract. And 6, overfeeding. Now, in the interest of time, I will only discuss 1 or 2 representative cases from each of the 6 groups, because otherwise we'll be here all day. All reports, however, will be provided to Lucy Letby's solicitors. So if each of these cases that I'm presenting today, it will be very brief, because these cases are quite long for many.
Yeah, they are.
And if we had to go through all the details, we'd be here forever. I can tell you they took days and days and sometimes weeks to go through each case in detail. So we're going to give you the highlights of what happened, talk about what the allegations were in the condition, and what the panel find. So baby 1 was a case of air embolism. This was a preterm baby, infant, who was born by emergency cesarean section. And he was well until the 2nd day of life.
Wow.
When he suddenly collapsed and had skin discoloration with blotchy patches of brighter pink on a bluish gray background. And he did not respond to resuscitation.
Oh, wow.
The allegation was that baby 1 died from injection of air into the intravenous line, causing air embolism and resulting in collapse, patchy discoloration of the skin, and eventually death. So, to begin, I will give you a little bit of background on the publications of air embolism. The prosecution, in part, based their allegation on a paper that I had written in 1989, where I described all 57 cases that had been published to that point in time. And it showed that the babies would present a certain number of symptoms or signs, and also that about 10% of them had skin discolorations of different kinds. At that time, I did not distinguish between arterial and venous air embolism. And,
embolism.
In this particular case, the allegation is that she injected air into the venous system, into the veins.
That's deliberate.
So there's a difference between arterial and venous, because the arteries carry blood to the body to supply the organs and the skin, whereas the veins actually carry blood away from the organs or the skin to the heart and to the lungs. And in the new paper that I published in December of 2024 in the American Journal of Perinatology, a copy of which will be in the summary report that you will receive, we actually separated the cases with arterial venous air embolism from the cases with venous air embolism. And what we found was that in the cases where air was injected into the veins, there were no cases of patchy skin discolorations ever described in the literature. So the notion that these babies can be diagnosed with air embolism because they collapsed and had these skin discolorations has no evidence in fact, right? None of this actually has ever been described. If this is true, it will be the first case ever described, but it's never been. And there's a reason for that. The reason is that in the arterial system, when you inject air into the arterial system, it goes directly to the skin or the blood vessels or to the organs. Whereas in the venous system, it has to go to the lungs first. And the lungs has a complex bed of very small blood vessels that filters out all the air bubbles that comes through, so that they don't actually get to the arterial system. Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system. But it has to go against pressure, because the pressure in the arterial system is higher than in the venous. And so what we found in the literature was that there were no cases that have been described where, in fact, these skin rashes have occurred. So let's do away with that theory, all right? The notion that these cases are air embolism because they collapsed and because there were skin rashes has no basis in evidence, okay? Let's be very clear about that. Now, so what can be the possible causes then? Why did this baby suddenly collapse? So we went into the history of this baby to see what actually happened. So in this baby, the mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly
So this is Dr. Lee. He's a neurologist. Let me see if I can find his bio a little bit. Dr. Shoal Lee. He's a retired Canadian neurologist who wrote academic papers in 1989, which was the basis of some of evidence at trial. So he's the one, when Lucy Letby went to trial, he wrote up some of the paperwork, which is supposed to be in line with the unaliving of the babies that she unalived, right? So what he's doing now, he's saying this is alternative medical reports that he has rewritten or wrote or has wrote, and he's detailing each individual baby, because he said he couldn't do all of them, right? Because like she did unalive quite a few babies. So he's saying that how basically that how because the papers no because it was alternative medical reports given, that what was that she was not the culprit of the unaliving of the babies, even though all fingers point in her direction. So he's basically saying that how she is like the innocent party at this point. Now they're being I can't even get my words right. They're being what's it call it campaigning to get her out of jail so they can have a retrial so that she could come out, so that she would to say that she's innocent. Now the last time I spoke about her, they were saying about the entrances and how other people might have been involved and all this, when the bosses was covering up for some misdemeanors. People caught her putting stuff, or things will happen when she's around to the babies, right? So when he's talking about that collapse, given overfeeding certain stuff, now there was evidence of all these things that was happening when she seems to be on shift. Now they're trying to twist it around the other way. Now I don't know. It's just crazy because I feel that how when if she does get out, it will happen again. But this time, the way she would do it, why you'll just see things happening, and then you'll be questioning who the culprit is. Because this time she will know how to hide it. This time, and I feel it's very dangerous that they're allowing this person that chance to go out and do it again, because that's exactly what you're doing at this point. Now I'm gonna put up the most of the conference because I feel that it's important that we hear. The lawyer was one of the people that are sitting at the conference table. At the conference table was her lawyer. He's the one sitting next door to Dr. Shaoli. The other one was I think he was one of the doctors that was also sitting on the table as well, on the panel. So it's like they're saying, oh, because like he gives the example of one of the mothers that where the lining of the water that holds the belly of the baby was broken, and she wasn't given antibiotics to help her. So when the baby came out distressed, so obviously that baby went into NICU, I think, and then later on there was a discoloration, and then the child was unalived. Now, I'm sorry because I know people's been through baby losses and stuff like that. Once again, I will apologize because of the deepness of this, but I've been following this for a while, not just now. This is not new what I'm talking about. I've been talking about this lady for a while, from when they got her to when they did the trial till now. And now she's tried a couple times to get appeals, retrials, and certain stuff. Now, his findings is very damning anyway because of what he says about each individual baby. So I only played a little bit, but what I'm gonna do, I'm gonna play the actual what was said. This is gonna be long-winded because it needs to be long-winded because at least like they're covering all the bases. The barrister, I want to show you the people that was on the panel, particularly. It's important I show the people who was on the panel. And I'm gonna find out their names as well. Let me see. I'm gonna find their names out. I think this is the one. Okay. So this is Dr. Lee, the barrister, and I think he's a doctor. I can't remember who she is, but these three, I got, and I looked up who they was. The barrister, he is Lucy Letby barrister, so he's on the panel, and so they decided to do a conference to put into perspective the each individual babies that was unalived at this time and what was the complications with them. Now it might be long, you might sit through all of it, you might not, but it's important that this is put as one part of my video because this might be an ongoing thing. There might not be an end to this thing. She might retry again. She might try reappeal again and try again. She might get knocked back, and then she might come back again, and a barrister might come with something else, and then they might go and do another conference and come back again, until whatever result that. But I believe that she is like Myra Hindley, the Moors murderer, because she literally showed no remorse. There was no remorse, and she took also keepsakes of the children that she unalived, like little things. I can't remember, but there was little things that she took. The parents that is in all this, once again, it's a slap in the face for the parents. Again, they don't seem to be getting their justice for their children. And it's not fair. It's not fair. Like the criminal seems to have more jurisdictions over the jurisdictions more than they do. And they're the ones who's had the loss. But I'm going to play the panel and I might forward in parts. Here's the sound. Like, this is the barrister talking.
Of the Lucy Letby issue, the miscarriage as I view it. And today, what we're here to do is to present a report which is the idea, the genesis of the case, because one of his papers was misreported, really misused, and he then came and gave evidence in the leave to appeal or the appeal?
The appeal.
In the appeal. Unfortunately, at that point, without effect. But this report, we will, just in practical terms, when Dr. Lee concludes his remarks, we'll issue copies of this, physical copies here in the room, which is basically the summaries of the report. And we will also send PDFs to all of your emails if we have them, so that you will have the
free with a new Opera GX. with you design that frees up
Oh, okay, you can hear me. Right, sorry for the empty ear. We're trying to sort out some technical difficulties, right?
an international expert panel to examine the medical evidence.
Okay, so I'm going to start this where he explains about each individual child, right? So it might take a bit of time for him to get through it, but it's important that he explains about each individual child, because remember, it's a case, and they have to bring in all types of experts who's written reports and stuff on the children, forensic reports, different things. So it covers what happened to the children. Now, like I said, right, they're trying to prove that how it wasn't negligent. That's what they're trying to prove. They're trying to show that Lucy Letby didn't unalive the children, that it was all negligent, and that how they didn't have the right medical things given to the children, and that's why they were unalive. But I believe differently, because I know some people's going to change their opinions on what happened, but to me, I feel, once again, I'll repeat, once a child unaliver, I don't even know the word, demiser, well, however you want to put it, that means that anybody that's underneath her care, if she does go back into work on the NHS or anything else or whatever, they're in her care, are in danger. Because if she can do that to little ones who's in NICU or whatever, that means she can do it to any type of vulnerable thingy, any type of vulnerable person, child, whatever, right? So to me, it's important to hear his findings anyway, because right, his findings is important, but then somebody might come again and contest it. And if they contest it and change or something else, because they're getting many experts, right? And especially if they have like the actual, I forget what it is now, the actual forensics, was it forensic autopsies, whatever, somehow the truth will come out. Somehow, I don't believe for a minute that this woman's innocent. I don't believe it. You can call me biased. I don't believe it, because it was very much stacked against her, right? I've done videos in the past about Lucy Letby, and it was very much stacked against her. It very much looked like what it was, and because the bosses did not, right, they was told several times that babies was not looking right, there was something wrong with them on her watch. So I'm sorry to go into speech mode, but I'm just trying to say my point, because it kept playing about. So that means that this person's a dangerous person then. So because Mr. Lee's finding is an alternative medical thingy to the actual whatever was found, that she should just get off. Before they were saying this another person, once again, they were saying another person clocked in, maybe came through one of the back doors, but there's cameras at the back, there's cameras when you enter, there's cameras when you go up to certain places of the children's place, the children's hospital. But anyway, let's listen to what Mr. Lee have to say, because he's got to put in his findings, isn't it? He's got to put in his findings. So they're saying no. Anyway, let me not just go there. Let me just listen, okay?
The panel is independent and worked under the agreement with Lucy and her lawyers that all findings would be released even if they did not favor the defendant. The defendant and her lawyers provided the panel with access to medical records and witness statements used in the trial. The panel self-determined how to examine the medical evidence, how to interpret the findings, and to produce a report independently. As chair of the panel, I issued the following instructions to the members of the panel. First, to review the medical records and determine the cause of death in their opinion, or injury. Second, to review and comment on the expert witness statements and opinions. And third, to provide an independent report about the causes of death or injury. The methods we used was that each case would be examined by 2 experts independently, who then submitted their reports to me, the chair. If their findings were in agreement, their conclusions were accepted as final. If their findings differed, a third member of the panel was asked to review the case, and a consensus opinion was then developed. Summaries of each case were developed by the chair and approved by the panelists who examined the case, and then shared with the whole panel. Strict confidentiality was observed. I'm the chair of the panel, and I invited members of the panel to participate on a voluntary basis and to work pro bono. Members of the panel, including myself, did not receive any benefits in cash or in kind, and even my trip here today is self-funded. The panel comprises 14 very experienced and well-known experts from highly prestigious institutions in 6 countries around the world, including Canada, the United States of America, Japan, Germany, Sweden, and the United Kingdom. They include 10 neonatologists, 1 pediatric surgeon, 1 pediatric infectious disease specialist, 1 senior neonatal intensive care nurse, and 1 other pediatric specialist. With the exception of myself and the member from the US, other members of the panel knew of the existence of the case, but otherwise had very little knowledge about it. I will give brief introductions to the members of the panel in a moment, and their biographies are in the summary report, so you can refer to it to see who they are and what they have done. We also relied on the reports of 2 external experts in engineering for information about insulin and C-peptide testing. And these experts were under instruction by those representing Lucy Letby. Now, the members of the international expert panel are as follows. I'm the chair. I'm Professor Emeritus at the University of Toronto, an honorary physician at Mount Sinai Hospital, and president of the Neonatal Foundation and founder of the Canadian Neonatal Network. I was previously the head of neonatology at the University of Toronto and the Hospital for Sick Children.
Hey, why does it seem so hard to sell your own service?
Next is Professor Eric Eichenwald, who is Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania in the United States. He's also the Chief of the Division of Neonatology at the Children's Hospital of Philadelphia and holder of the Thomas Friedrich McNair Scott Endowed Chair. Professor Helmut Hammler is the Senior Medical Director of Newborn Infants in Germany, and formerly he was the head of neonatology at the University of Ulm and Ulm Hospital. Professor Tetsuya Isayama is the head of the Division of Neonatology at the National Center for Child Health and Development in Tokyo, Japan, and the director of the Asian Neonatal Network. Professor Joanne Langley is professor in the Department of Pediatrics and Community Health and Epidemiology at the Faculty of Medicine in Dalhousie University in Canada. She's also the holder of the Canadian Institutes of Health Research GlaxoSmithKline Chair in Pediatric Vaccinology and head of the Division of Pediatric Infectious Diseases at the IWK Health Centre in Halifax, Canada. Professor Nina Modi is one of the most senior neonatologists here in the UK. She is the Professor of Neonatal Medicine and Vice Dean International at Imperial College London, Honorary Consultant to the Chelsea and Westminster NHS Foundation Trust, and President of the European Association of Perinatal Medicine, and a former President of the Royal College of Pediatrics and Child Health here in the UK. Sandra Moore, I don't have a picture, unfortunately, but she's the senior staff nurse at the South Lake Regional Health Centre in Newmarket, Canada, and a member of the Sullivan Medical Legal Experts, Richmond Hill, Ontario. Professor Michael Norman is professor and senior physician at the Department of Clinical Science, Intervention and Technology at the Karolinska Institute in Stockholm, Sweden. He's the chairman of the Swedish Neonatal Quality Register and founder of the International Society of Evidence-Based Neonatology, or EPNEO. He was also formerly the head of the Division of Neonatology at the Karolinska Institute Hospital. Professor Bruno Piedboff is Professor Titulaire et Pédiatrie at the Université Laval. He is coordinator des services cliniques de Rui de la Université Laval and director des affaires universitaires, Ministère de la Santé et des Services Sociaux à Quebec in Canada. Now, I will provide today, this is Professor Prakash Kumar Shah, who is professor at the University of Toronto in Canada, and he is also the head of pediatrics at the Mount Sinai Hospital, and has a number of different other appointments, including senior clinician scientist at the Lunenfeld Tannenbaum Research Institute, director of the International Network for Evaluation of Outcomes of Neonates, INEO, director of the Preterm Birth Network, and scientific advisor and past director of the Canadian Neonatal Network. Professor Nalini Singhal is Professor Emeritus at the University of Calgary and a member of the WHO AAP Helping Babies Survive program. She was also the head of neonatology at the University of Calgary previously. Professor Eric Skarsgård is a professor in the Department of Pediatric Surgery at the University of British Columbia in Vancouver, Canada, and also the director of the Canadian Pediatric Surgery Network. Professor Ann Stark is the professor in residence at Harvard Medical School and also director of the faculty development in the Department of Neonatology at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And she was formerly the NICU director at the Boston Children's Hospital in Boston. And finally, we have Professor Jeff Chase, who is a distinguished professor of engineering at the University of Canterbury in New Zealand. Now, he's not a member of the panel, but he is one of the experts who provided us with information about insulin and C-peptide testing that we'll be using in this presentation. Okay. Now, today I will provide you with a summary of our findings. Copies are available at the side table, and you will be able to access them after this press presentation. The full report will be provided to Lucy Letby's barrister later this month. Now, the panel examined all 17 cases with which Lucy Letby was charged, and they are labeled patient 1 to patient 17. The cases involve a number of different allegations about causes of death or injury, which can be roughly grouped into 6 categories. First, air embolism caused by injection of air into the intravenous system. 2, splinting of diaphragm caused by injection of air into the nasogastric tube. 3, dislodged nasogastric endotracheal tube causing collapse. 4, hypoglycemia caused by injection of insulin. 5, trauma to the abdomen or gastrointestinal tract. And 6, overfeeding. Now, in the interest of time, I will only discuss 1 or 2 representative cases from each of the 6 groups, because otherwise we'll be here all day. All reports will be provided to Letby's solicitors. So I will start with each of these cases that I'm presenting today. It'll be very brief, because these cases are quite long, many of them. And if we had to go through all the details, we'll be here forever. It took days and days and sometimes go through each case in detail. So we're going to give you the highlights of what happened, talk about what the allegations were in the conviction, and what the panel found. So baby 1 was a case of air embolism. This was a preterm baby, twin 2 infant, who was born by emergency cesarean section. And he was well until the 2nd day of life, when he suddenly collapsed and had skin discoloration with blotchy patches of brighter pink on a bluey-gray background. And he did not respond to resuscitation.
Here's how I would design a 30-minute problem-solving workshop for 7 people. First step.
The allegation was that baby 1 died from injection of air into the intravenous line, causing air embolism and resulting in collapse, patchy discoloration of the skin, and eventually death. So, to begin, I will give you a little bit of background on the publications of ableism. The prosecution, in part, based their allegation on a paper that I had written in 1989, where I described all 57 cases that had been published to that point in time. And it showed that the babies would present with a certain number of symptoms or signs, and also that about 10% of them had skin discolorations of different kinds. At that time, I did not distinguish between arterial and venous air embolism. And in this particular case, the allegation is that she injected air into the venous system, into the veins. So there's a difference between arterial and venous, because the arteries carry blood to the body to supply the organs and the skin, whereas the veins actually carry blood away from the organs or the skin to the heart and to the lungs. And in the new paper that I had published in December of 2024 in the American Journal of Perinatology, a copy of which will be in the summary report that you will receive, we actually separated the cases with arterial venous air embolism from the cases with venous air embolism. And what we found was that in the cases where air was injected into the veins, there were no cases of patchy skin discolorations ever described in the literature. So the notion that these babies can be diagnosed with air embolism because they collapsed and had these skin discolorations has no evidence in fact. All right? None of this actually has ever been described. If this is true, it would be the first case ever described, but it's never been. And there's a reason for that. The reason is that in the arterial system, when you inject air into the arterial system, it goes directly to the skin or the blood vessels or to the organs. Whereas in the venous system, it has to go to the lungs first. And the lungs has a complex bed of very small blood vessels that filters out all the air bubbles if they come through, so that they don't actually get to the arterial system. Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system. But it has to go against pressure, because the pressure in the arterial system is higher than. And so what we found in the literature was that there were no cases that have been described where, in fact, these skin rashes have occurred. So let's do away with that theory, all right? The notion that these cases are air embolism because they collapsed and because there were skin rashes has no basis in evidence, okay? Let's be very clear about that. Now, so what can be the possible causes then? Why did this baby suddenly collapse? So we went into the history of this baby to see what actually happened. So in this baby, the mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies that attack tissues in the own body. Now, these antibodies can trigger blood clots to form in arteries and veins. And during pregnancy, these antibodies can pass through the placenta to the neonate and lead to thromboembolism, which means clotting in the baby. Particularly happens if there is concurrent infection. Now, post-mortem of baby 1 showed that thrombus in the liver, which means that in fact there was a thrombotic event that happened in this baby after the baby was born. On the day of the collapse, the baby tissued at 1600 hours. Tissued meaning that the IV that was supposed to be in the vein somehow penetrated the vein and came out into the tissues. And so the infusion was not going into the circulation, was going into the tissues, and so the air was getting swollen because the infusion was coming out. And so because of this, they removed the IV and replaced it with an umbilical venous catheter. But the first insertion was malpositioned, and so they had to replace it again. Later on, a long was inserted at about 1900 hours. Now, they then took an X-ray, etc., to make sure it was in the right position, and eventually the infusion was restarted. But the infusion was restarted at 2000 hours. So there was a period of up to 4 hours when these lines were in, but there was no infusion. Now, here's the problem. Even in a baby without any problems, we avoid putting lines in without infusion, because if you do that, clots can form on these lines. In this case, the baby actually pre-infusion because of the antiphospholipid syndrome. And therefore, to have lines in there for 4 hours without infusion is a risk. All right? Now, what then happened was that minutes after the infusion was restarted at 20, baby 1 collapsed. It is most likely that there was a thrombus that formed on the tip of the catheter that then dislodged when the infusion was started, and it migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. It is also possible that baby 1 had placental fetal vascular malperfusion. So what's that? This condition in which fetal villi in the placenta present small thrombi that can travel to and occlude small blood vessels in like the heart, brain, and if a small thrombi land in an artery supplying a critical structure like the brainstem, it can also cause sudden death, and they are very hard to find on post-mortem because these vessels supplying these critical areas of the brain or the heart are very tiny. And so all you need is a small thrombus to occlude it. When you're doing a post-mortem, you're doing cuts to see whether you see anything. And you have to actually cut exactly where that thrombus is in order to identify it. So just because a post-mortem doesn't identify it doesn't mean it isn't there. Right? And in the second condition, which is fetal vascular malperfusion, these collapses can occur 1 to 2 days after birth. So one of these 2 causes probably caused it, and we think it's the first one because of the temporal relationship with the lines that were inserted, the predisposition to formation of clots on these lines if you don't infuse it, and then the occurrence of the collapse just minutes after the line was infused. So our conclusion is that baby 1 died from thrombosis and that there was no evidence of air embolism. Because in this baby, the allegation for air embolism was that, number 1, the baby died, we could not find a reason for it. Number 2, this baby had this collapse accompanied by these skin discolorations, which was consistent with what the allegation was with air embolism. And what we are saying is, first of all, the second reason doesn't hold, because air embolism by the venous system does not produce these kinds of skin discolorations. Number 2, there is a plausible and reasonable reason why this happened, which is what I just explained. So for both those reasons, we feel that this diagnosis is wrong, that this is not pulmonary air embolism. In fact, this is because of thrombosis. Now the next baby, I forgot to show you that, but hopefully you understood what I was saying. The next baby is baby 4, which is another case of air embolism. Now baby 4 was a term baby who was born by emergency C-section after prolonged premature rupture of membranes. She became pale and floppy at 12 minutes of life and required resuscitation. She continued to have respiratory distress afterwards. She was then admitted to the neonatal unit, and continuous positive airway pressure support for the respiratory distress was started, and antibiotics were started, but only 4 hours later after the baby had admitted to the NICU. The chest X-ray showed pneumonia. On the 3rd day, the baby became mottled, had dark brown and black tracking lesions across the trunk, and 2 evolving purpuric-looking patches on the abdomen. She had repeated episodes of apnea and desaturation until final collapse and death. Now the allegation is that baby 4 was a stable baby after the baby was born and admitted to the NICU, and then on day 3 of life, the baby suddenly collapsed, and that this was due to injection of air through the intravenous system, causing air embolism, resulting in patchy discoloration of the skin and death.
If you want to make a full-time income from home working part-time, you need
Now, first of all, I would like to just repeat what I said earlier, that there is no evidence that air embolism through the veins results in patchy discoloration of the skin. So let's just dismiss that, all right? That's not a consideration. So what could this be? Well, first of all, this baby was born after prolonged premature rupture of membranes. What it means is that all the babies in utero have a membrane around them that protects them. And if the membrane is ruptured, infection can ascend. Also, membranes often rupture because of infection. So for that reason, there is a standard treatment guideline in this country and in other countries that if there is prolonged premature rupture of membranes, the mother should be given antibiotics right away so that the baby can be protected from any infection. In this case, that was not done. The mother did not receive antibiotics. Second, there were important delays in the admission, diagnosis, and treatment of the baby after the baby was born. The baby was admitted to the neonatal unit only 3.5 hours after birth, at which point she was noted to be cold, blue, dusky, and in respiratory distress. She had polycythemia, which means that she was looking very dark in color, and she had infection because the blood test at the time showed white cell count that was very high and a neutrophil cell count that was very high, which are all indicators of infection. So there was a long delay in admission and treatment. Now don't forget the antibiotics should have been given a long time ago during the labor itself. So this was a very long delay. You were talking about half to a full day or more where the baby was not receiving antibiotics when in fact there was already infection. On top of that, the blood gas that should have been taken to see how the baby was doing was not taken until after 4 hours after birth. And then when it was taken, it showed very high carbon dioxide and respiratory acidosis, meaning that the baby was in respiratory failure all this time, and nothing had 4 hours. The continuous positive airway pressure support for the baby was again started nearly 4 hours later after birth, despite the baby having respiratory. Now, she was eventually electively intubated, but 3 attempts were required, waited, and ventilated. And these delays subjected the baby to unnecessary acidosis, high CO2, and delay of antibiotic treatment. This was not a stable baby, as alleged by the prosecution witness. And in fact, this baby continued to deteriorate for the next few days until final collapse, with worsening symptoms of infection as we went along. So she was admitted and was already sick on that day. On the following day, she developed fever. She had intolerance when the CPAP was removed. In other words, she could not tolerate coming off the CPAP support. She had continuing deterioration of blood gases over the next day. She had increasing metabolic acidosis. All these indicates that the infection was in fact getting worse. The baby was not stable. Then on the next day, on day 3, she further deteriorated with rising CRP. Now, CRP is the test we do to see whether the CRP is going up, it means the infection.
Panel, because I think I said it wrong. Okay, so let me go back to the panel before we get back to Dr. Shu. Let me get put underneath so I can see who is who. I think I got that one wrong, so I'm standing corrected. Before we move back to Dr. Shu. I want to get who exactly is on the panel. Right. So there's Professor Moody, Barrister, Mark MacDonald, and David Davis, the MP, and there's also Dr. Lee, and he's also the campaigner to get Lucy Letby out. So he's doing a lot of campaigning, going on TV programs, explaining certain things, and yeah. So while Mr. Shu was talking, I was trying to look up some of what he was saying because I like to know what they're talking about. Like some of it I get. I know what amorism is. I know what certain stuff is what he's talking about. So I kind of get some of what he's explaining. The discoloration of the skin. You know, when babies, when they're not breathing, they lose color. Some lose color, or they lose color in their skin until when you bring them back to life, when you give them that breath of air or whatever. So I kind of get what he's talking about. And I just want to know exactly and pinpoint the parts he's talking about. Now, while he was talking, I did look up one of the things that he was talking about as well, because I feel it's important to know exactly what these pathologies is as well. So even if you don't get to understand all the pathologies he's talking about, but you should understand some of the pathologies what he's talking about. So the one I did look at was the first one what he spoke about. I should just leave it on the screen a minute. Let me just leave this one on the screen and then just do what I normally do. Let me leave it on the screen.
Due to a measles case in the community, please call before masking and visitation changes. Due to high rates of respiratory illnesses in what is an arteriovenous malformation, AVM. Arm and hand enlargement from arteriovenous malformations. Arteriovenous, arteriovenous malformations, AVMs, are tangles of blood vessels, arteries and veins. Normally, very small tubes, capillaries, connect arteries to veins. An AVM happens when the capillaries are missing. Without capillaries, blood from an artery flows under high pressure directly into a vein. This can make the blood vessels swell under the skin. It can also cause them to burst and bleed. An AVM can limit your child's ability to move and may cause other serious health problems. An AVM can happen anywhere in the body. It may affect a small area, such as a finger, or an entire arm or leg. AVMs can also affect internal organs, including the brain or spinal cord. What causes an AVM? The exact cause is not known. Some AVMs are caused by changes, called mutations or variants, that happen early in pregnancy. The mutation starts in one cell. Any cells that divide from that cell will continue the mutation. This is called a mosaic mutation. The abnormal gene is not passed down by parents, not inherited. AVMs may be a symptom of a like-Proteus syndrome. AVMs may develop as part of a condition passed down from parent to child, inherited, such as or hereditary hemorrhagic telangiectasia, HHT. Heart Center at Seattle Children's.
That's one of it, because he mentioned discoloration. Let's see what discoloration in the baby signals. Or shows, should I say. So yeah, I was thinking jaundice as well. Jaundice is one of them. Blue baby syndrome. Patches. Blue baby syndrome.
Our pediatric cardiologists and cardiac surgeons have more. Please accept our privacy terms. You can change or revoke your preferences at any time by clicking on Privacy Settings in the footer at the bottom of the page. The total number of vendors we work.
Oh, what's going on, man?
With is 25.
Oh,
We believe.
You won't let me see it. Won't let me do it. Oh, didn't know you do that. Skin colour changes in newborns. Because this is after birth, isn't it? So it's to do oxygen, not enough oxygen in the body. Let's see what they say. Skin color change. Skin change in newborn. Skin color changes due to something happening inside the body. Some color changes are normal, others are signs of problems. The changes described below can happen to any newborn. Can't say some of them words. I need my little helper.
Skin color changes in the newborn. In newborns, skin color changes are often due to something happening inside the body. Some color changes are normal. Others are signs of problems. The changes described below can happen to any newborn. But skin color changes may be more obvious in babies born early, premature babies or preemies. This is because they have thinner skin than full-term babies. Acrocyanosis. With acrocyanosis, the baby's hands and feet are blue. This is normal right after birth. In fact, most newborns have some acrocyanosis for their first few hours of life. It happens because blood and oxygen are circulating to the most important parts of the body, such as the brain, lungs, and kidneys rather than to the hands and feet. The problem goes away as the baby's body gets used to new blood circulation patterns. Later, acrocyanosis can come back if the baby is cold, such as after a bath. This is normal and will go away by itself. Cyanosis. Cyanosis can be a blue color around the mouth or face, or over the whole body. It happens when the baby's red blood cells aren't carrying as much oxygen as expected. It may mean the baby is not getting enough oxygen. If you notice cyanosis, tell your baby's healthcare provider right away. Mottling. Mottling occurs when the baby's skin looks blue or pale and blotchy. There may also be a bluish marbled or web-like pattern on the baby's skin. The parts of the skin that are not blotchy may be very pale. This is called pallor. Mottling is not uncommon in premature or ill babies in the neonatal intensive care unit. In other babies, it could be due to a congenital heart problem, poor blood circulation, or an infection. Tell your baby's healthcare provider right away if you notice mottling. Jaundice. Jaundice is a yellowing of the skin and the whites of the eyes. It usually starts in the face. Then, it moves down to the chest, lower belly, and legs. It happens because the body is breaking down red blood cells, a normal process after birth. The breakdown releases a yellow substance called bilirubin. This causes the yellow color. This substance is processed by the baby's liver. It leaves the body through the urine or stool. Jaundice occurs in about half of all babies after birth. And it usually goes away by itself. But sometimes a baby's liver can't process bilirubin as quickly as needed. This is especially true of babies born early, premature babies or preemies. Treatment may be needed to help the bilirubin break down and get rid of the yellow color. If your baby is jaundiced, alert their healthcare provider. Other skin color changes. Also tell your baby's healthcare provider if you notice. 1. Redness around the baby's umbilical cord or circumcision site. This could be a sign of infection. 2. Bruising. 3. Red spots, caused by broken blood vessels. This may be a sign of injury or infection. Or it could be due to a problem with the blood's ability to clot.
Hold on, I just found something else. There's something what he mentioned. I think I found it because I've been looking for it while I've been sitting here. I think he explained it, but let me see if it's this one.
As a library, NLM provides access to scientific literature. Inclusion in 2010 OG 13. Sepsis is almost invariably associated with hemostatic abnormalities ranging from subclinical activation of blood coagulation, hypercoagulability, which may contribute to localized venous thromboembolism, to acute disseminated intravascular coagulation, DIC, characterized by massive thrombin formation and widespread microvascular thrombosis, partly responsible of the multiple organ dysfunction syndrome, MODS, and subsequent consumption of platelets and coagulation proteins causing, in most severe cases, bleeding manifestations. There is general agreement that the key event underlying this life-threatening sepsis complication is the overwhelming inflammatory host response to the infectious agent, leading to the overexpression of inflammatory mediators. Mechanistically, the latter, together with the microorganism and its derivatives, causes DIC by 1, upregulation of procoagulant molecules, primarily tissue factor, TF, which is produced mainly by stimulated monocytes macrophages and by specific cells in target tissues. 2. Impairment of physiological anticoagulant pathways, antithrombin, protein C pathway, tissue factor pathway inhibitor, which is orchestrated mainly by dysfunctional endothelial cells, ECS, and 3. Suppression of fibrinolysis due to increased plasminogen activator inhibitor 1, PI1, by ECS, and likely also to thrombin-mediated activation of thrombin-activatable fibrinolysis inhibitor, TAFI. Notably, clotting enzymes not only lead to microvascular thrombosis but can also elicit cellular responses that amplify the inflammatory reactions. Inflammatory mediators can also cause, directly or indirectly, cell apoptosis or necrosis, and recent evidence indicates that products released from dead cells, such as nuclear proteins, particularly extracellular hist-1s, are able to propagate further inflammation, coagulation, cell death, and MODS. These insights into the pathogenetic mechanisms of DIC and MODS may have important implications for the development of new therapeutic agents that could be potentially useful, particularly for the management of severe sepsis. Introduction. Sepsis is a serious and relatively common disorder and represents the leading cause of mortality in non-coronary intensive care units worldwide. Sepsis is almost invariably associated with hemostatic abnormalities ranging from isolated thrombocytopenia and/or subclinical activation of blood coagulation, hypercoagulability, to sustained systemic clotting activation with massive thrombin and fibrin formation and subsequent consumption of platelets and proteins of the hemostatic system, acute disseminated intravascular coagulation, DIC. From a clinical standpoint, isolated thrombocytopenia, which is seen mainly in viral infections, is only occasionally serious enough to cause a bleeding diathesis.
Okay. Right. What I'm looking up right now is the aneurysm part. Embolism. Let me see. Oh, let me put it in a baby. So that must be fluid to the brain, I would imagine. It could be one. Let's see if it's going to show up. So this is probably the one I got before. Yeah, so it was an embolism.
Amniotic fluid embolism, anaphylactic syndrome of pregnancy. Amniotic fluid embolism, anaphylactic syndrome of pregnancy. Amniotic fluid embolism, AFE, is a dangerous and life-threatening complication that occurs during delivery or shortly after giving birth. Amniotic fluid embolism is very difficult to diagnose because the symptoms can be similar to other serious complications during childbirth. Its exact cause is unknown. AFE is very rare. Cleveland Clinic is a nonprofit academic medical center. Advertising on our site helps support our mission. We do not endorse non-Cleveland Clinic products or services.
Oh, come on.
Policy.
Get to the point.
Overview.
Yes, let's get to the
Amniotic
book.
fluid embolism is a severe allergic reaction to amniotic fluid getting into your bloodstream when you give birth. What is amniotic fluid embolism? Amniotic fluid embolism, AFE, is a rare and life-threatening complication that occurs when a pregnant person gets amniotic fluid into their bloodstream just before, during or immediately after childbirth. Amniotic fluid is the liquid that surrounds the fetus in your uterus during pregnancy. It's made of mostly water but also contains fetal cells and tissue. For reasons that are mostly unknown, some people have a severe allergic response to amniotic fluid mixing with their blood. An amniotic fluid embolism can lead to heart and lung failure, which causes several complications due to a lack of oxygenated blood in your body. This could include cardiac arrest, your heart stops beating. People with AFE may also bleed uncontrollably from their uterus or C-section incision. AFE happens suddenly and is unpredictable. It's extremely challenging to treat and requires emergency medical care. Amniotic fluid entering your bloodstream is a normal part of the birthing process. In most people, it doesn't cause an allergic reaction. Researchers aren't entirely sure why some people react to amniotic fluid this way while others don't. AFE is also known as anaphylactic syndrome of pregnancy. How common is AFE in pregnancy? AFE is rare. It affects 1 in every 40,000 deliveries in the United States and 1 in every 53,800 deliveries in Europe. The symptoms of AFE are similar to other complications during childbirth, like uterine rupture, placental abruption, and eclampsia. This makes it more difficult to diagnose AFE as the cause of the complication. What increases your risk of amniotic fluid embolism? Risk factors for AFE are hard to predict because it's rare and hard to study. However, current research points to a few possible risk factors, including 1. Advanced maternal age, being older than 35 during pregnancy. 2. Expecting multiples, twins, triplets, or more. 3. Fetal distress, changes to the fetal heart rate. 4. Issues with the placenta like placental abruption. 5. Preeclampsia or eclampsia. 6. Polyhydramnios, too much amniotic fluid. 7. Cervical tears. 8. Labor induction medications or procedures. 9. Having a C-section delivery. 10. Operative assisted deliveries, forceps delivery or vacuum extraction. Symptoms and causes. What are symptoms of amniotic fluid embolism? Signs and symptoms of AFE develop suddenly and quickly. They're similar to symptoms of other complications during pregnancy and childbirth, making the condition more challenging to detect. Possible symptoms include 1. Shortness of breath or difficulty breathing. 2. Sudden drop in blood pressure. 3. Pulmonary edema, fluid in your lungs. 4. Abnormal heart rate. 5. Bleeding from your uterus, C-section incision, or 4. Intravenous sites. 6. Fetal distress. 7. Agitation, confusion, or sudden anxiety. 8. Chills. What are the complications of amniotic fluid embolism? AFE can cause serious complications for you and the fetus. For you, these include 1. Heart and lung failure. 2. Losing consciousness. 3. Seizures. 4. Excessive bleeding. 5. Disseminated intravascular. The fetus is at risk of complications depending on when an amniotic fluid embolism occurs. An emergency delivery may be necessary if symptoms begin before the fetus is born. Babies who are delivered once AFE has already begun are at risk for not getting enough oxygen. Lack of oxygen could cause impairments in their nervous system or brain. What causes amniotic fluid embolism? There isn't a known cause of AFE. The placenta breaking down during labor or delivery may trigger an immune response in some people, leading to AFE. It's not clear why this happens in some people and not others. Can AFE...
Okay. So one of the mothers had an emergency delivery. Let's go back to Mr. Lee. Did I get it? Let's go.
And these lines were in, but there was no infusion. Now, here's the problem. We avoid putting lines in without infusion, because if you do that, clots can form on these lines. In this case, the baby actually predisposes to clot formation because of the antiphospholipid syndrome. And therefore, to have lines in there for 4 hours without infusion is a risk, all right?
The reason why I looked into it a little more, because I wanted to get a greater understanding, a little bit more of what he's talking about, a little more, even though, like I said, I kind of got an idea what he's talking about, but it's good to have a better understanding so that if you hear certain words again, you know exactly what it is. Because he talks about the lining of one where the mum had to have antibiotics, which I think was interesting. And he talks about another, but there's quite a few babies he goes through. So I think it's about 4 or 5 of them he do. So now we're just gonna listen, and I'm not gonna interrupt this. I'm just gonna let it play.
What had happened was that minutes after the infusion was restarted at 2000 hours, baby 1 collapsed. It is most likely that there was a thrombus that formed on the tip of the catheter, and it migrated after thrombi that can travel to and occlude small blood in major organs like the heart, brain, and liver. And if a small thrombi lands in an artery supply, sudden death, and they are very hard to find on post-mortem, because these vessels supplying these critical areas of the brain or the heart are very tiny. And so all you need is a small thrombus to occlude it. When you're doing a post-mortem, you're doing cuts to see whether you see anything. And you have to actually cut exactly where that thrombus is in order to identify it. So just because a post-mortem doesn't identify it doesn't mean it isn't there, right? And in the second condition, which is fetal vascular malperfusion, these collapses can occur 1 to 2 days after birth. So one of these 2 causes probably caused it, and we think it's the first one because of the temporal relationship with the lines that were inserted.
Welcome to Whiskey and World Cup.
The predisposition to formation of clots on these lines if you don't infuse it, and then the occurrence of the collapse just minutes after the line was infused. So our conclusion is that baby 1 died from thrombosis, and that there was no evidence of air embolism. Because in this baby, the allegation for air embolism was that, number 1, the baby died, we could not find a reason for it. Number 2, this baby had this collapse accompanied by these skin discolorations, which was consistent with what the allegation was with air embolism. And what we are saying is, first of all, the second reason doesn't hold, because air embolism by the venous system does not produce these kinds of skin discolorations. Number 2, there is a plausible and reasonable reason why this happened, which is what I just explained. So for both those reasons, we feel that this diagnosis is wrong, that this is not pulmonary air embolism. In fact, this is because of thrombosis. Now the next baby, oh, I forgot to show you that, but hopefully you understood what I was saying. Next baby is baby 4, which is another case of air embolism. Now baby 4 was a term baby, who was born by emergency C-section after prolonged premature rupture of membranes. She became pale and floppy at 12 minutes of life and required resuscitation. She continued to have respiratory distress afterwards. She was then admitted to the neonatal unit, and continuous positive airway pressure support for the respiratory distress was started, and antibiotics were started, but only 4 hours later after the baby had admitted to the NICU. The chest X-ray showed pneumonia. On the third day, the baby became mottled, had dark brown and black tracking lesions across the trunk, and 2 evolving purpuric-looking patches on the abdomen. She had repeated episodes of apnea and desaturation until final collapse and death. Now, the allegation is that baby 4 was a stable baby after the baby was born and admitted to the NICU. And then on day 3 of life, the baby suddenly collapsed, and that this was due to injection of air through the intravenous system, causing air embolism, resulting in patchy discoloration of the skin and death. Now, first of all, I would like to just repeat what I said earlier, that there is no evidence that air embolism through the veins results in patchy discoloration of the skin. So let's just dismiss that, all right? That's not a consideration. So what could this be? Well, first of all, this baby was born after prolonged premature rupture of membranes. What it means is that all the babies in utero have a membrane around them that protects them. And if the membrane is ruptured, infection can ascend. Also, membranes often rupture because of it. There is a standard treatment guideline in this country and in other countries that if there is prolonged premature rupture of membranes, the mother should be given antibiotics right away so that the baby can be protected from any infection. In this case, that was not done. The mother did not receive antibiotics. Second, there were important delays in the admission, diagnosis, and treatment of the baby after the baby was born. The baby was admitted to the neonatal unit only 3.5 hours after birth, at which point she was noted to be cold, blue, dusky, and in respiratory distress. She had polycythemia, which means that she was looking very dark in color, and she had infection because the blood test at the time showed white cell count that was very high and a neutrophil cell count that was very high, which are all indicators of infection. So there was a long delay in admission and treatment. Now, don't forget the antibiotics should have been given a long time ago during the labor itself. So this was a very long delay. We were talking about half to a full day or more that the baby was not receiving antibiotics when in fact there was already infection. On top of that, the blood gas that should have been taken to see how the baby was doing was not taken until after 4 hours after birth. And when it was taken, it showed very high carbon dioxide and respiratory acidosis, meaning that the baby was in respiratory failure all this time, and nothing had been done for 4 hours. The continuous positive airway pressure support for the baby was again started nearly 4 hours later after birth, despite the baby having respiratory distress. Now, she was eventually electively intubated, but 3 attempts were required before she was actually intubated and ventilated. And these delays subjected the baby to unnecessary acidosis, high CO2, and delay of antibiotic treatment.
Are you a tech business founder? Are you doing too many jobs, working too hard, but now seeing growth stall? I used to struggle with exactly the same thing until I discovered these 3.
This was not a stable baby, as alleged by the prosecution witness. And in fact, this baby continued to deteriorate for the next few days until final collapse, with worsening symptoms of infection as we went along. Let's see what happened. So she was admitted, and as I said to you earlier on, she was already sick on that day. On the following day, she developed fever. She had intolerance when the CPAP was removed. In other words, she could not tolerate coming off the CPAP support. She had continuing deterioration of blood gases over the next day. She had increasing metabolic acidosis. All these indicates that the infection was in fact getting worse. Her baby was not stable. And then on the next day, on day 3, she further deteriorated with rising CRP. Now, CRP is a test we do to see whether there's infection. And if the CRP is going up, it means the infection is getting worse. If the CRP is going down, it means it's getting better. And this was going up. There were repeated episodes of apnea and desaturation, again indicating the baby was clinically getting worse, not better. She then developed prolonged coagulation times. Coagulation times means how long does it take for your blood to clot? And normally, for all of us, it should clot within a certain period of time. If it takes longer than that, it means that there's a coagulation defect. Something is wrong with your blood. And in this case, the coagulation time was increased. Now, this is a serious development because it indicates that the infection is going out of control. Most of us, when we are infected, we are sick, whatever, the coagulation times don't change. But if the coagulation times change, it means that this baby is going into what is called disseminated intravascular coagulation. And this is a condition that appears when a baby is severely infected and severely ill because it causes spontaneous coagulation of the blood throughout the whole circulatory system. The blood just starts to clot everywhere. And as it clots, it consumes the coagulation factors, and that's why you see a coagulation defect. And then that leads to spontaneous bleeding in all the organs and elsewhere in the body. So when you see something that's starting to cause coagulation defects, this is in fact an early sign of DIC that is developing. And so the blood vessels in the skin are compromised because if you are clotting the blood vessels of the skin, they compromise the blood flow, which together with hypoxia, triggered dilation and contraction of small vessels in the skin, which then results in the skin discoloration that you see, and tracking lesions and so on. And she ultimately collapsed and deceased. So this baby died of systemic sepsis, pneumonia, and disseminated intravascular coagulation. The mother should have received intrapartum antibiotics prior to delivery. There was delay in recognizing respiratory distress after birth. There was delay in starting antibiotics and delay in starting treatment for the respiratory distress. We did not find any evidence of air embolism. All right. Now the next baby is baby 9, where the allegation is that the baby received nasogastric tube air and then subsequently was also given air through the IV into the intravenous system, which caused air embolism. Now, baby 9 was a preterm infant with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease, who had repeated episodes of apnea, desaturation, and bradycardia, needing resuscitation during the hospital stay. And the baby was in hospital for quite a period of time. The baby also had an episode of lung collapse and reports that there were thick gelatinous airway and oral secretions. And one of the registrars, who is a mid-level doctor in the NICU, stated that it is not unusual for babies on breathing support to get secretions, but it was a bit unusual for them to be so stubborn at being removed like in this baby. And after each period of apnea and desaturation, they had to resuscitate the baby using back and mask ventilation, and then the abdomen was distended. And abdominal x-rays taken after that showed gaseous distension of the intestines. At 2.5 months, she had an episode of severe apnea, bradycardia, desaturation, and heart block, and then deceased. So it was alleged that air was injected into baby 9's stomach through a nasogastric tube, leading to recurrent episodes of abdominal distension, which then splintered the diaphragm and caused respiratory arrest and failure, needing resuscitation. It was also alleged that on the 13th of October, that the apnea alarm was deliberately turned off, resulting in delay and response to a collapse. And then on the 15th of October, air was injected into her intravenous tubing, causing air embolism and death. So we looked at this case in detail, and what we found was that baby 9 was a very preterm baby with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease. Also, that in fact, surveillance cultures, which are normally done after a baby is admitted to the unit from outside, to make sure that there are no dangerous bacteria being brought into the NICU. So they routinely culture all these babies after admission. And in this case, the surveillance culture revealed a bacteria called Stenotrophomonas maltophilia, which is a gram-negative bacteria from her endotracheal tube. And the doctors in the unit were duly notified that that was the case. Now, this particular bacteria is unique because it is a multi-resistant opportunistic pathogen that can colonize the airway in biofilms that are resistant to antibiotics and impossible to clear in patients with chronic lung disease. The thick secretions can block the endotracheal tubes, which led to the endotracheal tubes constantly being blocked and replaced, and interfere with ventilation in the small airways of these vulnerable infants, which together with other factors like chronic lung disease can lead to recurrent episodes of apnea, desaturation, bradycardia, respiratory failure, and collapse. And decolonization with Stenotrophomonas maltophilia would have further compromised her ventilatory capacity. Now, her initial abdominal distension was likely due to sepsis causing ileus, or to lactose intolerance because it's a family history and the stools were positive for reducing substances. But the subsequent repeated abdominal x-rays showing intestinal gaseous distension were all taken after resuscitation and bag and mask ventilation, so that the air was likely introduced by the resuscitation, not because the air was there previously. Right? Also, a nurse explained that the reason that the apnea alarm did not sound was because the apnea alarm is set to go off if there is a 20-second period where there are no breaths. But because this baby was gasping at less than 20 seconds, the apnea alarm wasn't triggered. So it wasn't because it was switched off. It was because the baby was gasping, and so it wasn't triggering the alarm. Right? Now, this baby was not treated for Stenotrophomonas maltophilia, and there is no evidence that air embolism was at all involved. We concluded, therefore, that baby 9 died of respiratory complications caused by respiratory distress syndrome and chronic lung disease that were complicated by the Stenotrophomonas maltophilia colonization. The doctors failed to respond to routine surveillance warnings that this baby was colonized with this bacteria. They did not recognize the diagnosis. They did not treat her with the appropriate antibiotics which would have cleared this bacteria. This was likely a preventable death. There is no evidence of air causing splinting of the diaphragm or of air embolism. There was no evidence that the alarm was turned off. In fact, the evidence is that the alarm was not turned off.
Don't even think about life insurance until you've heard this. In the life insurance industry are absolute
Give me 1 second, I'm missing a page here. There we go, thank you. Now, baby 11 was a preterm baby who was resuscitated at birth and had a number 2 sized endotracheal tube. There was 3 traumatic attempts. The baby was then ventilated. A 94% air leak was detected and ventilation was continued. At 1.5 hours of age, she desaturated. The consultant bagged the baby, but found that the chest could not move. In addition, he applied a capnography test, which was negative. He then removed the tube, re-intubated the baby, and the baby then recovered and was subsequently transferred to Elder Hay Hospital. So let's just understand what actually happened here. So when a baby, has collapsed, and the tube is in place, the consultant first has to check to make sure the tube is there. Because if the tube is in the right place, he would then ventilate the baby using bag and mask and so on. And in this case, he said that he attempted to ventilate the baby. In other words, he disconnected the endotracheal tube from the machine. He put on a bag and mask and he bagged it to see whether the chest would move. And he said the chest did not move. And if the chest did not move, then potentially the tube was not in the right place. Secondly, he applied the capnography test. So this is a device that you connect to the endotracheal tube, and it measures carbon dioxide. So if the tube is in the endotracheal the endotracheal tube is in the trachea, then when the baby expires, carbon dioxide will come out, and this device will measure it. So if you measure carbon dioxide, you can say that the tube was in the right place. If you don't measure carbon dioxide, it is potentially not in the right place and potentially could have been removed. Right. The consultant, therefore, concluded and alleged that baby 11's first episode of clinical deterioration, which I'm talking about, was caused by deliberate dislodgement of her endotracheal tube because failed to move the chest, and carbon dioxide was not detected on capnography. He also alleged that the incubator alarms were deliberately turned off to prevent prompt rescue response because he did not hear the alarms when he entered the room. So we examined the evidence to see what actually happened. First of all, when the baby was born and required resuscitation, they took 3 times to intubate the baby because they had difficulty intubating the baby, and it was traumatic. And finally, they put in a size 2 tube. Now, this resulted in a 94% air leak. What that means is that when you pump air in, whether it's by a bag or machine, 94% of the air is actually leaking out. So only 6% actually gets into the lung. All right? That's kind of like using a straw and blowing through a garden hose and hoping that you can inflate something at the end of the garden hose, right? It doesn't work. So as a result, ventilation was ineffective because 94% of the air was leaking out and only 6% was entering the lung. Effective gas exchange could not occur, and mechanical ventilation could not generate sufficient pressure to keep the small air spaces in the lung open. So this led to gradual collapse of the small air spaces in the lung and deteriorating gas exchange. When the tipping point was reached, the baby decompensated, desaturated, and collapsed. Now, when the small air spaces in the lungs are collapsed, if you try to reopen these collapsed air spaces, it actually requires relatively high pressures because they are collapsed, and therefore you need higher pressure to actually open them. With a 94% air leak, bagging will not do the job because the air is all leaking out. It doesn't get into where it's supposed to go. In addition, the consultant was using a device called the Neopuff. Now, the Neopuff is actually a safety device because it's a valve that is pressure limited. So when you bag, it limits the amount of pressure you can give so that you don't give excessive pressure to the lungs. Now, in this case, however, because the lungs are collapsed, you actually need higher pressure to open it up. And so when you're using a Neopuff, you're not delivering sufficient pressure. So both these reasons will account for why the chest did not move when the consultant tried to bag the baby. The capnograph, as I explained, measures CO2. But with a 94% air leak, the CO2 is all leaking out. And the capnograph requires the CO2 to build up in the tube to the point where it can be detected. If the air is all leaking out, the CO2 is all leaking out and you cannot detect anything. And there's good studies to show that when the air leak is more than 20%, your ability to measure CO2 starts to drop. By the time you're 80% air leak, you measure nothing. And we've got a 94% air leak here. So for those 2 reasons, there's actually no proof that the tube was even dislodged. It was probably in the right place. It's just that the consultant didn't know what he was doing. The consultant also stated that he did not hear the alarms. But another nurse, in her testimony, stated in her statement that when I returned to the unit, I immediately became aware of the alarms sounding from baby 11's incubator, and I rushed in to help. So there is actually a statement from another nurse saying that the alarms were not off. They were actually working. Perhaps the consultant just didn't hear them. So our conclusions was that first, there is no evidence to support a dislodged endotracheal tube. The clinical deterioration was caused by the use of an undersized endotracheal tube, and the initial intubation was traumatic and poorly supervised. The consultant did not understand the basics of resuscitation, of air leak, of mechanical ventilation, and how the equipment that he was using, that were commonly used in the neonatal unit, like the Neopuff and capnograph, actually worked. There is evidence that the incubator alarms were not turned off. Next, we're going to talk about baby 6. That's what we call an alarm.
That alarm was good.
Yes. Wasn't turned off. Now, baby 6 was a preterm twin 2, borderline intrauterine growth restricted baby, male, who was born by emergency cesarean section. He had mild respiratory distress syndrome and hyperglycemia requiring insulin treatment. And on the 5th of August, at about 1:30 in the morning, he then developed sepsis and hypoglycemia and was treated with antibiotics and intravenous glucose infusion. Over the next 17 hours, his glucose remained low, ranging from 0.8 to 2.4. And this was despite repeated doses of 10% dextrose to try and raise the blood sugar. In fact, they were given very frequently. Every time they tested it was low, they would give another bolus injection of 10% glucose. And that's like less than 2 hours between each dose. So it was very frequent that they were giving this. And still the sugar didn't come up. At about 1000 hours, which is about 9 hours after the initial hypoglycemia, it was noticed that his IV line was in fact tissued. And as I explained earlier, tissued means that the line was out of the vein, and therefore it was infusing fluid into the tissues. And it was also noted there was extensive swelling and induration, meaning very hard, of the right groin, thigh, and leg. What that means is that this infiltration had gone on for quite a long time, because otherwise you wouldn't have this amount of extensive swelling and induration of the groin, thigh, and leg. In other words, the IV that was giving sugar wasn't actually giving any sugar, because it was actually going into the tissues. So the baby wasn't receiving any sugar, and that was why the sugar stayed low. Now, when this was noticed, the IV was turned off appropriately. So it was stopped at about 1000 hours. And then a long line was put in. And at 1200 hours, the IV was restarted. And at 1200 hours, it is also routine in this unit that all the IV bags are changed. So that for this baby, one would presume that the IV bag was not also changed. And then the sugar still remained low. So that at 1900 hours, the dextrose infusion was increased to 15% from 10%, and the hypoglycemia then resolved. Now, it was alleged that baby 6 was given exogenous insulin through the infusion bag because there was a prolonged period of hypoglycemia. Further, that when the infusion was stopped from 1000 to 1200 hours because of the IV being infiltrated, the sugar actually went up from 1.3 to 2.4. So how can that be? If you're not giving sugar, the sugar should be dropping. And so the conclusion that was drawn by the expert witness for the prosecution was that the IV bag must have contained insulin, and that's why it kept the sugars low. And when you stop the insulin because the IV was stopped, then the sugars came up. Thirdly, that the blood glucose after the infusion bag was changed at 1900 hours caused the sugars to then recover, so that insulin must have been put into the bag before the the bag was changed at 1900 hours. And finally, that they had done a test which showed that the baby had high insulin but low C-peptide, which indicates that exogenous insulin was used. So what does that mean? What happens is that when your body produces insulin, there's a small protein called a C-peptide that is cleaved off. So whenever you produce 1 unit of insulin, 1 C-peptide protein is also cleaved off. So you would expect that if you produce insulin yourself and it was not given externally, that both of these would rise. If, however, you're insulin from outside, then the insulin will go up, but the C-peptide would not go up because there was no production by the body and no that would be produced, right? And in this baby, when they measured, they found that the insulin level was very high and the C protein was low. So it must mean that the insulin was being given by the outside, somewhere outside, and not being produced by the baby itself. So let's look at the evidence here. First of all, the hypoglycemia started with sepsis, which often precipitates hypoglycemia, all right, in these babies. And it was prolonged because the IV infiltrated for several hours. We don't know how long. We just know that at 1000 hours, the nurse found that this baby had a swollen groin and thigh and leg. So for some number of hours before that, the baby wasn't getting any dextrose. And that probably explains why the baby was hypoglycemic during this time. The second thing is that when hypoglycemia persisted, despite 10% dextrose, a higher dose of glucose should have been used. Because if you're giving 10% dextrose infusion and there's still hypoglycemia, it means it's not enough. You should be increasing the amount of glucose you're using. And that wasn't done until 1900 hours. So for the whole day, the same amount of glucose was being used. Instead, what they did was to give repeated doses of 10% glucose. The problem is that that's actually the wrong treatment. Because the way to treat hypoglycemia is that you give a continuous infusion and then you titrate it to increase the amount required so that the glucose will then come up in the blood and comes to the level that you require. When you give repeated bolus doses, which means that you just pump a big dose in at one time, of 10% dextrose, it actually worsens the hypoglycemia. Because every time you pump a surge of glucose in, the glucose rises in the blood. There's a surge of glucose. And that triggers a surge of insulin production by the pancreas, because that's what it's programmed to do. And that surge of insulin will then force down the glucose, and then you get hypoglycemic again. So you end up with a yo-yo pattern where you see hypoglycemia, you pump in your sugar, it causes a surge of insulin, the blood sugar then drops, you test it again, now it's low again. Then you pump in more glucose, and it just makes it worse and worse. It's a vicious cycle that you keep doing. This is a very basic thing. We teach all our medical students not to do this. All right? This is what was done here. Now, then when the IV tissued, there was lack of glucose infusion for many hours because of the swelling, as I talked about. And that was probably one of the reasons why this hypoglycemia was so prolonged. The next thing is that when the infusion was stopped from 1000 to 1200 hours, it was alleged that the blood sugar rose from 1.3 to 2.4. So how can that be if there's no sugar being given? What was not said was that in fact the blood sugar was 1.4 at 1146 hours. In other words, for that whole period of 2 hours where the glucose was not infusing, the blood sugar was actually not rising. The figure of 2.4 was measured after 1200 hours when the IV had been restarted. So there is no evidence that in fact this baby's sugar was rising because of the IV being stopped. Right? Also at 1200 hours, the IV bag was changed. Now the infusion bags in this hospital were prepared in the pharmacy. They were then brought to the unit and stored in a cupboard. And were changed every day at 1200 hours. So this baby would have had at least 2 bags of IV fluid during that period of time. And in order for this baby to have had insulin introduced into the bag, it would have to have been done multiple times into multiple bags. Because if the bag was changed at 1200, then you would have to give insulin into that bag as well in order for that to happen. Now, the blood sugar rose after 1900 hours. It was alleged that this was because the IV bag was changed in 1900 hours, and it was changed. But it was not because the bag was changed. It was because in 1900 hours, the dextrose was increased to 15%. So the baby got better, because now you were giving the appropriate amount of sugar to this baby. Right. So what about this problem with the insulin and C-peptide? Because as I explained earlier, the blood test showed high insulin and low C-peptide. And we know that this is something that has been well tested in adults and in older children. The problem is that this has never been tested in preterm infants. And preterm infants are not just little people. Preterm infants are different. They have different physiology and biology compared to adults and older children. They behave differently. And just because we see something that applies and is valid in adults and older children doesn't mean it's valid for preterm infants. So Professor Jeff Chase, whom you saw a picture of earlier on, is someone who has been studying this his whole life. This is what he does for a living. His whole career he has been studying this. And what he reported, and a copy of his report is in the summary report that you receive later on, he reported that preterm infants have different insulin and C-peptide standards than adults. exogenous insulin is unlikely to be the cause of hypoglycemia for several reasons. First, the C-peptide in this case would have been low for an adult or older children, but it was not low for preterm infants. In fact, the level for this baby would have been at 20 to 45 percentile of all preterm infants. In other words, right in the middle. Average for a preterm infant. It was perfectly normal. Right. Second, if the insulin was really that high, the potassium levels would have been reduced. But in this baby, the potassium levels were normal. So that couldn't have been the case. The glucose level should be lower if exogenous insulin was used. And the insulin C-peptide ratio was within the normal expected range for preterm infants. All right? Because the experts in the trial were using standards for adults and for older children. They do not apply to preterm infants. And finally, that preterm babies have a lot of antibodies. And these antibodies bind insulin. And when you measure insulin, it measures not just the active insulin in the blood, it also measures the insulin that is bound to these antibodies. And so you get a falsely high level of insulin when you measure the insulin in these preterm infants. Right. Finally, that the immunoassay that is used is unreliable because there are many interference factors. For example, if you have sepsis, if antibiotics, if antibodies, it will all cause these measurements to be wrong. And therefore, you get false positive insulin readings. And this baby had all of the above. Baby had sepsis and antibiotics, baby had autoimmune antibodies, etc. And therefore, we concluded that baby 6 had prolonged hypoglycemia because of sepsis, prematurity, borderline intrauterine growth restriction, lack of intravenous glucose when the long line infiltrated for a prolonged period of several hours, and also poor medical management of the hypoglycemia. In addition, baby 6's insulin level and IC ratios do not prove that exogenous insulin was used, and are in fact within the normal range for preterm infants. Preterm infants, and especially those with illnesses and drug treatments like antibiotics, have different normative standards compared to healthy adults and older children. Right. Next is baby 15. Baby 15 was a preterm second triplet born by in-labor cesarean section, and the triplets were extracted very quickly, one after the other, a minute apart. And at 36 hours, he had rising heart rate and respiratory rate, temperature instability, and mild abdominal distension. On day 3, there was further deterioration. The abdomen became more distended. Visible loops of bowel were seen. The baby was uncomfortable after feeds, vomited, had a high blood lactate, carbon dioxide, bilirubin, and acidosis. He was intubated and given high-pressure ventilation. He then collapsed and had purpuric discoloration of the right chest. Resuscitation included intubation, ventilation, cardiac massage, and needling of the abdomen, which failed. So the baby died. Post-mortem showed a ruptured subcapsular hematoma of the liver. Now, it was initially alleged that baby 15 received inflicted blunt trauma to the abdomen, causing purpuric discoloration of the chest and a ruptured subcapsular hematoma of the liver, and that the abdomen was distended because air was injected through the nasogastric tube to cause gaseous distension of the intestines. And later, the accusation was then changed to say that, in fact, there was deliberate injection of air into his intravenous system to cause air embolism, collapse, and death. So let's see what really happened. Baby 15 collapsed because the subcapsular hematoma ruptured, causing acute major hemorrhage into the peritoneal cavity that was sufficient to cause the hemoglobin to drop by half. In other words, half your blood was lost into the abdomen because of the rupture. Now, you should know that for all of us, if you lose 20% of blood volume, you go into shock. When you lose half the blood, pretty much you exsanguinate to death, right? So this is a very major event. Now, the subcapsular liver hematoma is the result of traction or shear forces that are applied to the thin, fragile liver capsule through the hepatic ligaments. In baby 15, it was highly likely that this was the result of extremely rapid delivery, and this is a well-recognized cause of birth injury. And one of the other triplets also had the same subcapsular hematoma, although it was not this severe. So the fact that two of them had the same problem, again, confirms that this was likely caused by birth injury. All right? In other words, when a baby is suddenly precipitously delivered and the traction forces are applied, that's when you get this injury. When you apply blunt trauma to the chest, you cannot generate the kind of shear or traction forces required to cause subcapsular hematoma. It doesn't happen, right? You can hammer the chest all you want. It's not going to cause this kind of a subcapsular hematoma. Now, bleeding into a subcapsular hematoma is characteristically initially very slow because there's a capsule around the liver, and so it is contained by the pressure of the enveloping liver capsule. And in the early stages, the clinical signs are insidious and difficult to recognize. Now in this baby, as the baby got worse, they then intubated the baby and ventilated the baby with high pressures. That's again a mistake, because when you use high pressure ventilation, it decreases the venous return to the heart. And that causes congestion of the liver, which actually makes it worse. Now the slow deterioration is characteristically followed by an acute collapse when the liver ruptures, when the capsule ruptures, and this releases blood into the peritoneal cavity. Now, the significance of the rising heart rate and falling pH before terminal collapse were not recognized, because what was happening was that there was insidious bleeding going on into the liver capsule and into the liver, and that was causing the heart rate to go up and the acidosis and so on, and this was not recognized. And then a needle was blindly inserted into the abdomen to try and relieve the abdominal distension. Well, this is something you don't do, and you don't do blindly. And unfortunately, this may have penetrated the right lobe of the liver, causing further injury. And this was noted by the pathologist as parenchymal hematoma and laceration. Blunt direct trauma to the abdomen or the chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in the liver protected by the lower chest wall. The gaseous distension of the intestinal tract was likely due to swallowing of air and insufflation during non-invasive respiratory support, and not due to injection of air through the nasogastric tube. The suggestion that there was air injected into the intravenous line is nothing but conjecture.
Hi everybody, I didn't see you because I was on another side of the thing, keeping an eye on the length of the video. Hi Christine, hi Native. Yeah, things just, yeah, okay. Yes, what did you say something? Oh, I better not do it like that, it keeps going funny. Let me see. Hold on, let me put you up on screen to make it easier for me. Okay, there we go. These people use the word spells to fool the people. Yeah, because now people's remaking their videos, like they're rethinking what they said about her originally, right? So he's saying that how it wasn't, she didn't put no ear into their into the baby's tubes. She didn't overfeed them. She didn't do this. She didn't do that. But once again, I'll say this: if she gets off and she convicts again, this time she ain't gonna do it so that people can whistleblow on her. She's gonna do it in such a way they will not see her. So if she gets off, right, she might just go do it another way because, you know, and they're saying that how it was the hospital's mistake, like, you know, certain things wasn't done and these are the new evidence. So I feel that how what even though she had keepsakes, because I just went and looked over some stuff and checked, she had some keepsakes of the chill or certain things I can't remember all the keepsakes. She had keepsakes and everything, and therefore that means that how right she was not going to come. She's not going to do the stuff in front of people because she knows that how if she gets catch, she'll get whistleblowed, and that means that how the safeguarding of vulnerable children, safeguarding of young people, the safeguarding of elders. If they especially if she changes hospitals and they move her to a different place, not necessarily a NICU, it might be in another place, and she might convict again. So considering that how so now they're saying that how it could be a miscarriage of justice on their part, and I think it's not. Now I'm listening to him, and I just checked out some of the stuff what he was talking about, like the amorism, I forgot the ultravenous things, what it consists of, so I can get a better understanding, because I know what I know what amorism is, but it's better sometimes to get an even deeper understanding of it, especially when it occurs in children. Discoloration of the skin, what does it mean in children? Which means that how it could be in patches, or it could be jaundice, or it could be something else. The main thing is one of the children, where they was getting better, and then they passed later on. So like, and he said that how they didn't use his report in her retrial, or in the trial, and certain stuff. So it's all like smoke screams going on. Now other people is in agreement with what is being said, and I don't know, I'm not in agreement with it. I'm not in agreement because the evidence was too damning. It was too damning, and I feel it could be worse next time. All right, it could be worse because like she is a Myra Hindley. There's a more murderer called Maya Hindley, or was it Rose West? There was quite a few who was in hospitals as well, who also unalive children. So I feel it's quite dangerous, like to expecting mums, premature babies, all sorts have to be put into effect to think about how right you go to give to have a baby. Right, the baby is in another space and you're in another space, because like remember, right, they separate the mothers for the babies, they put in intensive care, what's it so-called NICU in American terms, and then they are looked after, they are fed, they all wired up to air, oxygen, and other stuff, right? So that's why I just let it play. Like after I put out a couple things on what he said, because I literally went and looked him up, some of it, not all of it, because it's a lot to look up. And like so they are campaigning to get her out. They did a birthday party in Clapham for her, which I find is very weird. Yeah, I just. Oh yeah, and the next thing they were saying that how it might have been another person who might have come into into where the children is and unalived them. When my kids was born, I kept my eyes open all the time. When my wife was resting, just me being protected. Yeah, because you gotta be protective. Hold on, let me see if I can highlight what you guys are saying. These people are using worse spells, absolutely. Yes, it's like you have no faith. You will have no faith in the system. This is why loads of people is having home births. Loads of people's having home births. But I assure you, right, they're gonna find a way to stop that. Because right now they're trying to stop certain stuff right now to do with autistic children and certain stuff they're trying to stop. Because yes, people take liberties and they do certain things, but that's just a whole other conversation. But it's the mere fact that how right you had a premature baby, you've trusted people with your premature baby, you had a C-section, you've had one of those births, isn't it? One of those births. And that's why I'm glad I showed Shaida and Badil, because they went private. They went private. They didn't go into a normal hospital. He literally went private. She had her own room, her private room. He was able to stay there, and she had her bed. So the child wasn't taken from them. The child was in the room with them, and that's how I think it should be. And it's smoke screams going on right now. I don't know why, but it looks like they want to use Dr. Lee's reports. That's why I'm letting them just talk, because I'm thinking, let them just talk. Right now, people's changing their tune on TikTok. Oh well, it might have been an injustice. The miscarriage is an injustice. She lost her life for. One person said, yeah, but she was only in there like from last year. That's the kind of chats that's going on right now. So, yeah. So I'm just going to let it play. You can listen. I'm listening. I am literally listening. I mean, I walked in and out, but I'm listening. So, that's why I'm not saying nothing. That's why I'm not saying nothing, right? I leave it to the opinions of the people on my chat, on my community, on my comment section to deal with that. That's a sure sign of an unaliver. They like to keep trophies of the victim. Yes, well, she did do. She kept trophies of the victim. She did. I just went and I looked, and I'm going to show them, because I feel they're not thinking rationally. This, like, you know what I mean? They want to get her out. Because what normally happens to people who is tried for these type of things, when they go to jail, it doesn't be good for them. As we know what's going on with Axel right now, it's not good for him right now. It's not good for another person right now, because he unalived a child. Some nurses, no offense to all of them, but some do not use the word called compassion for life, treat humans like livestock. Yes, it's like a meat market. In and out. Some of them's never had children. It's all theory based. So they go by their theories. That's the same with most things. Like me, like when you're in the situation, right there in the situation, that's when it's more real. When you haven't been through what people has been through, you don't understand it. You will never get it. There's no empathy. There's no anything. It's just it's just in and out. Here you go. Placid movements. But people is losing that touch for empathy, even though there is some people who still got it, but empathy is not all there. What does it say? Native, I agree with you. However, they do treat animals over here with more compassion than humans. Yes, they do. That is right. That's true. So I'm going to let him play, and we're just going to listen. And so I'm just letting it play. For how long it takes for him to finish, how long this live will finish.
Hey, real quick, tickets just went live for AdCon 2025. You need to come to the page right now and get the full details. We just revealed the speakers.
Baby 15 died from a subcapsular liver caused by traumatic delivery, resulting in hemorrhage into the peritoneal cavity and profound shock. This was not recognized antepartum. Now, the last baby I'm going to talk about is baby 7.
I'll find it for you. Copy.
Sorry, a couple of my pages are missing here. I need his alarm to go off again. Now, baby.
Imagine 15 babies. 15 babies. And actually, to me, it doesn't matter the number. It doesn't matter the number. The fact that she has the balls to do it. 15 babies is a lot.
Baby 7 was a very preterm baby with premature rupture of membranes, severe hyaline membrane disease, bilateral pulmonary interstitial emphysema, hypoglycemia, anemia, thrombocytopenia, patent ductus arteriosus. And so this baby had a lot of chronic problems, all right? And at 14 weeks of age, the baby suddenly developed projectile vomiting, large watery stools and desaturation, followed by apnea 2 hours later. The abdomen was purple and distended, and the baby was then transferred to Arrow Park Hospital, where baby was treated for sepsis, rising CRP, and then eventually recovered. And the allegations were that this baby was deliberately overfed.
Now, I did already put up about the sepsis. If you go at the beginning, I think the beginning or a little while in, you will hear what sepsis is, if you don't know what sepsis is, all right? So it's important that we learn these terms in case they come up again. Aneurysms, I forgot the next one he said. He said another word. I can't remember it right now. We have to remember some of these terms, so if they pop up again in another retrial, we know exactly what they're talking about, because they will use terminology that you don't understand, and you need to understand the terminology of certain stuff, which is called a pathology, which is like, you know, what is the cause, what is the problem, what is the cause of it, and what's the treatment given, right? That's the pathology. And also which part of the body that is the problem, which means that how you have to understand whether it could be the cardio, the chest cavity, the nodes, the neurosystem, the brain, which is what he deals with because he's a neurologist, the choangular, I think there is, the femur. I forgot all the parts of the body. I haven't done my anatomy physiology for a while, but I feel that how if I have to go back and read on it again, just for this case alone, I'll do it, because one the lining, because I was thinking placenta is the lining that the baby, the sac that the baby's in, which they said was thin. And when she came out very distressed. The mother wasn't given antibiotics to save the baby in the sac. So when she was born, she was very, and one of them that was unalive. So it's important that you learn these terms. It's important, right? Whether you are masseuse, whatever, it doesn't matter. I feel people just need to learn certain terms anyway, because sometimes when you're told about these terms, you have no idea. The way how he's talking to a bigger community, the upper community, and they know the certain terms and the certain thingy, and they're all doctors and nurses and this one and that one and that one. It's the same with the law. You have to know the law, which even I need to start looking into myself. So it's a lot. But let him continue. Let me see what he said. Well, we are all aware what was taking place during lockdown. Yes, that's true. Who is Lucy Letby? Lucy Letby. I'm gonna have to do it after he's finished saying, because I have a video on that. I don't need to explain that one. There's a video, but I'll put it up briefly so you can see. Yeah. Ever notice whenever the so-called people above us in charge get in trouble, there is always some kind of virus, or is it just me looking into history? History has a way of being recycled. Yes, it does. Let's continue. Let's hear the rest of what he's got to say, because he's read like most of the babies. I think he reached. Oh, I lost count. There's so many of them. I lost count. I think I was listening to about 3 of them, but like, because he goes in so deep with each what was wrong with them and why this was wrong with them and this is what happened to them, and this is the ending part. Like, you know what I mean? Overfeeding and all that. Oh yeah, I know you know who she is. Oh yeah, you're diving in deep. Oh yeah, okay. Yeah, I know you know who she is because like you was here when I was talking about her before, Christine.
This caused the baby to vomit. And further, the air was injected into her stomach through the nasogastric tube, causing the vomiting and clinical deterioration because the air in the stomach splintered the diaphragm and caused respiratory failure. So let's see what really happened. The first thing we can see is that the baby in fact had infection on the night of the vomiting because she clinically deteriorated with desaturation and apnea. And her CRP continued to rise over the subsequent days after she was transferred to Arrow Park Hospital. That showed that this baby was infected. And so the vomiting and the apnea that we saw at this hospital was the start of symptoms arising from that infection. All right? It had nothing to do with anything else. Second, it is not uncommon for the CRP to climb after onset of clinical symptoms when there's infection. So you cannot separate the two events and say, oh, the infection is just separate from what happened here. This was the start of the infection. She had vomiting and large watery stools, which are actually very common in enterovirus infection, which is quite common in these babies. It would explain why all the blood, urine, cerebrospinal fluid, and respiratory cultures were all negative for bacteria, because this was probably a viral infection by enterovirus, not by bacteria. But the CRP was high, indicating there was an infection, right? So this is a viral infection. In addition, large watery stools are not consistent with overfeeding. If you overfeed, you can get vomiting. You do not get large watery stools. On the other hand, enterovirus infection is associated with large watery stools. Now, the abdominal distension and discoloration of the abdomen are common when babies are ill with ileus, and they usually disappear when the baby recovers. The abdominal x-rays showing gaseous distension of the intestines were all taken after bag and mask ventilation of the baby and are consistent with air being introduced by bagging and ileus, which means that the intestines are not moving in a sick baby. The blood-stained fluid coming up the trachea are most likely the result of a trauma during intubation. Chest x-ray post-intubation did not show any consolidation suggestive of pneumonia or pulmonary hemorrhage. At the Elder Hay Hospital, she received 7 days of antibiotics and she recovered after 7 days, which is consistent with enterovirus infection because this is a self-limiting disease and it recovers after a few days and they get better. So baby 7, in our opinion, had vomiting and clinical deterioration because of infection, possibly enterovirus infection, which can cause all these signs and symptoms. There is no evidence to support air injection into the stomach or overfeeding. So, just to summarize all the findings we had in terms of the medical problems that we are seeing at this hospital, we found that the medical histories were incomplete. It was a failure to consider the obstetric history. There was disregard for surveillance warnings about bacterial colonization. There was misdiagnosis of diseases in these babies. They were caring for babies that were probably beyond their expected ability or designated level of care. There were unsafe delays in diagnosis and treatment of acutely ill patients. There were poor skills at resuscitation and intubation. There was poor supervision of junior doctors in procedures like intubation. There were poor skills in basic medical procedures like insertion of chest tubes. There was lack of understanding about basic things like respiratory physiology and how to mechanically ventilate the baby. There was poor management of common neonatal conditions like hypoglycemia. There was lack of knowledge about commonly used equipment in the NICU like Neopath and capnograph. There was failure to protect infants who were at risk, for example, hemophilia, from trauma during intubation. There was a lack of teamwork and trust between the health professions.
Hey there, you're listening to State of Survival Radio. Calling all survivors who can hear this, please.
There were also statements given by many witnesses which point to serious resource and infrastructure deficiencies. And these specific concerns that were expressed by individuals include inadequate numbers of appropriately trained personnel in the unit, lack of training for assigned nursing roles, inadequate staffing and workload overload, poor plumbing and drainage resulting in the need for intensive cleaning in the unit. And this is a potential factor in Stenotrophomonas multifida infection because this particular bacteria thrives in water, and particularly in dirty water and bad water. There was poor environmental temperature control in the facility. There was difficulty in finding a doctor when the need arose. There was congestion at the medication cabinet and preparation trolley. There was lack of appropriate facilities for sterile preparation of drugs. Some high-risk infants should have been born and cared for at higher-level institutions, but were born and cared for in this hospital. And there were delays in transfer of sick infants to higher-level facilities when the need arose. So these are not things that we invented. These are statements given by people who worked in the unit. Our conclusions of this panel, therefore, was that there was no medical evidence to support malfeasance causing death or injury in any of the 17 cases in the trial. Now, I've only presented you 7 of the cases, 7 of the 14 of which there are convictions, but the others are similar. It's just nuances, changes of variation in the details, all right? Death or injury of all the affected infants were due either to natural causes or to errors in medical care. There were serious problems related to medical care of patients at this hospital. There were problems related to teamwork and interdisciplinary collaboration at the Countess of Chester Neonatal Unit. In summary, ladies and gentlemen, we did not find any murders. In all cases, death or injury were due to natural causes or just bad medical care. Lucy was charged with 7 murders and 7 attempted murders. In our opinion, the medical evidence doesn't support murder in any of these babies, just natural causes and bad medical care. Our full report will go to Lucy's barrister later this month, and then it will be up to him and the courts to decide what next to do. So in closing, I'd like to thank you for attending this press conference. I hope our findings breathe comfort and closure to the families of the affected infants, and our hearts and sympathies go out to them. I would like to thank Sir David Davis and Mr. Mark McDonald for their efforts, and Sir Davis in particular for graciously organizing and chairing this meeting. I would also like to thank the members of the international expert panel. They are some of the most experienced and best minds in neonatology in the world today, and they are incredibly busy people who have given freely and generously of their time to this effort to uncover the truth. And they have done so with objectivity and impartiality, knowing that regardless of whatever they say, whether it's favorable or unfavorable to Lucy, it would be released, because they did not come into this to free Lucy, they came into this to discover the truth. Finally, we hope the authorities will consider our findings seriously and act accordingly, because you will not find a better panel of experts anywhere in the world. These are the best in the world that you can find, and they come from the most prestigious institutions. They come from Boston's Children's Hospital, Children's Hospital of Philadelphia, Hospital for Sick Children in Toronto, Imperial College, Karolinska Institute, Ulm, Tokyo National Child Center, and so on. Right? These are day, because it is possibly the first time that a group will have come together voluntarily and pro bono to provide clarity to some very vexing questions about a troubling case. If you are looking for the truth, you don't need to go any further. I'll be happy to take any questions.
Thank you very much indeed. That's an astonishing.
The first question would be, if our panel found so many problems with the medical care provided by this team at this hospital, how is it that Dr. Evidence found none? Because in none of the 17 cases did he even identify one problem with the medical care provided at the hospital. The second question I would ask is this. He seemed to be rather selective in his use of information. So if he wasn't selective, if all the information was used, in fact, you would come to a very different conclusion than what he came to. Just take, for example, the case of the hypoglycemia, where he said there was no sugar for 2 hours and the blood sugar grows, therefore it must be insulin. In fact, he missed the one important value, which was at 1146, showing that the blood sugar, in fact, did not rise. So was he just careless, or was it deliberate? The next question that I would ask is, even when there's an obvious cause of death, why did he go around looking for malfeasance? So I would ask you to ask these three questions and ask Dr. Evanstad. If you can answer those three questions, I think you have the answer to your question. Sir.
Can I ask Professor Modi, with your experience of the BMA and Royal Colleges and the NHS, does this evidence point to yet another maternity scandal in the NHS?
Thank you very much. I want to make it quite clear that I'm here in a personal capacity. I'm not representing any organisation, not the BMA, not the RCPCH or any other organisation. What we have shown is, as Professor Lee has outlined to you, that there were plausible reasons, very, very plausible reasons for these babies' deaths, and that there was a combination, if you take the totality of the 17 cases, there was a combination of babies being in the wrong place, delivered in the wrong place, delayed diagnosis, and inappropriate or absent treatment. It was not our brief to comment on the wider issues facing the NHS or on other maternity reports that have been issued recently. But I would say to you too, there are clearly systemic factors that are at play that we've identified, as well as individual factors which we have also identified.
Yeah.
So David Davis, I want to ask you a question. Looking at all this together and the conviction, what does that tell you about the British justice system and what the evidence you're looking at today? And also, where does the case go from here? Where could it go from here? She's lost a bit to appeal, of course we all know that. So where could it possibly go now?
First, the British judicial system. Back in 2011, the Law Commission published a report challenging the handling of expert evidence in court. Who appointed it, who paid it, how they selected it, and so on. This case is a case study in why that report should have been implemented. It hasn't been, and it should be now. Right? Secondarily, there is currently a Law Commission investigation into the basis of conceding appeals, of allowing appeals, sorry, not conceding appeals. That too, I think, is necessary, overdue in fact, and we need to reconsider the basis on which we accept or define evidence as new for the purposes of appeals. At the moment, as I said in the debate in Parliament, at the moment, if you were unlucky enough, if your lawyers, for whatever good reason, tactical reason, did not deploy a piece of evidence and you tried to use it later, you can't. So if your lawyers make a mistake, you're banged up for life, hard luck, you know. Now, that's not justice. It may be judicially convenient, but it's not justice. Sorry, what was your last question? Well, that's really a question for Mark.
Oh, it is.
Yeah.
Hello, hi. So, Criminal Cases Review Commission had the application. They will be waiting eagerly for the report, which is going to be coming at the end of the month. Then it's up to the Criminal Cases Review Commission to decide whether or not to refer it back to the Court of Appeal. What you've just heard and what will be in the report is overwhelming evidence that this conviction is unsafe and must be immediately referred back to the Court of Appeal. So we will be waiting patiently for them to make that decision.
Well, that's going to be interesting then. Okay, I'm definitely going to be watching and see how this goes then, because like people, my friends saying that how she might have got set it up, being in the wrong place at the wrong time, but she had keepsakes of the children. I don't know what to think no more. I think that when I hear stuff now, I'll go wait. I've got to sit down and wait and see what else goes on with it, because they make you question even your own mind after they said one thing and now they're saying something else, and now they look like they're going to overturn it, and I'm just like, it doesn't make sense to me. Okay, it doesn't make sense. I'm sorry. Like it was like my friend's like, she's innocent. I'm thinking, I don't know, I don't know, I don't know. I'm gonna see where this leads to, because like it was like the village, with the flames and the pitchforks and everything else, and now they're saying something else. But they've been trying to appeal her case for a long time. They've been trying to appeal her case. I think last year, I think she tried to appeal about, I think it's 2 times or 3 times, 2 times. So yeah, but this guy is one of the campaigners, as I said, as I mentioned earlier. He's a campaigner and he's a barrister. So he's the one who's dealing with her case. But I'm gonna let it play.
I, for one, find it very hard to understand how they cannot refer it back on the basis of what we've heard today. Yes.
Tessa Chapman, fine views. To Mr. McDonald, have you discussed these findings with Lucy Letby herself, and what was her reaction?
What I have done since I've instructed is not talk about Lucy and not talk about where she is and what she's doing. I've focused upon the issues in relation to an unsafe conviction. But she has hope, and that's all I can say.
At the back there. Sir.
Hi, Josh Halliday from The Guardian. Can I just ask, how many of the 7 deaths do you think were preventable? Deaths are often multifactorial. And sometimes even when you do all the right things, death occurs. That's just life, right? So if you say, could we have prevented these deaths? I can't tell you for sure which ones we can prevent. What I can tell you is that the appropriate treatments were not given. And may some babies have survived because of it? It's possible. I cannot predict which baby will and which cannot.
Yes.
In terms of
Name and company.
Sorry, Anuk Curry, freelance filmmaker.
Yeah.
In terms
Is it still possible for a woman to find love in her 40s and above? The 3 ways we level the playing field for
of potential clinical negligence, is it possible that this could be investigated now? This is a question for David Davis. So David Davis, while the whole trial and potential appeal are ongoing, I mean, where do we stand with this? We're hearing some very damning accounts.
Yeah, our principal aim is not pursuing clinical negligence, it's pursuing justice. And what all of this does is provide a completely alternative explanation for the deaths and collapses of those children. An explanation which, in my view,
But you are making people question their own mind now, like they're thinking. Like some people, when they saw the evidence, when they saw the situation, when they heard the parents talking, when I can't think of whatever, when they heard, they're saying Ravi had something against her. I don't know, man. It just sounds too clear cut to me. I don't know. I just can't just agree like that. I can't, because it was just too damning. The evidence was right. The evidence, the parents, the whistleblowers. So are you saying that we can't listen to our whistleblowers no more? So if a whistleblower sees something, does that mean that they'll be questioning when you see something that's going wrong in the NHS or medical situation? Would that mean that they will take longer to do something before it gets out of hand to how many people's on a live or demised or however? Because that's making people think that how you guys are putting out false information, false flags on people. Maybe the articles what you put out was wrong. I don't know what to think. Right at this moment, I feel like what I've got to do, I've got to go back and watch everything what I've done, what I've spoken about, go over it again because it was a massive gap. Then all of a sudden, Dr. Lee comes from nowhere and said that how his evidence wasn't given into the court and that how she could have been innocent and that how it's a miscarriage of justice. I don't know. I really don't know. I mean, though the one that I featured with one content creator, she was talking on a medical thing as well, medical level of I think it was cross contamination was mentioned and certain stuff. So yeah, I don't know. I'm not even taking this for so because that means that how right you could come and you can whitewash something. It could be one thing and then it be something else. Even though with medical papers you can actually doctor them to suit. You can make it sound what it is. I don't know. That's what I'm saying. I don't know. Right. But all I know is damning. It was really damning. And yes, the whole country was up in arms with it because they're babies. They're in NICU. They're premature babies, sick babies, basically in one. And then this lady comes and does whatever. And now you lot are saying something totally different, totally the opposite. So are you saying that how it could, like before they were saying there could be another person who also was unaliving the infants? So I don't know. I'm just gonna let it play. You know, they want to campaign. They want to take her out. They want to take her out of the prison because I feel they know the deepness of it. My friend said because like she's young, and what and I can't remember the other stuff she said, but yeah, I don't know. I'm kind of like, nah, I'm not convinced. I'm not convinced, and I don't know why. I don't feel. I wish I can get my card reader to even do a reading because I'm sure she can deep dive in this one. This will be ideal for her to deep dive in because there's so many questions right now. I'm literally like questioning my instincts, my gut instincts, because I know, like me and my daughter was right with the toddlers. The stories never match up. When the stories don't match up, the thing don't make sense. Right? It doesn't match up. When something doesn't match up and it doesn't make sense, it doesn't sound right. The parents came out and spoke. And I just feel that the parents is the ideal witness in all of this as well, because they was there. But they're saying the medical report says different. Once again, the medical report says different. So everybody's like, okay, the neurologist has spoken, and they had a whole panel of doctors and blah 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 blah, and now she's innocent all of a sudden. I don't know. I'm questioning. But anyway, they're just playing.
Should have been exposed at the trial, not now. So that's really our only interest. Justice generally, both for Lucy, but also for the parents of the children who must have a terrible cloud hanging over them.
Is this the first that the parents would have heard about this?
I would imagine so. Yeah. I don't know.
Yes.
Yeah, Nadine.
Dr. Lee, between June 2015 and June 2016, the Countess of Chester neonatal was a level 2, which attracts substantial additional funding from the NHS, which means it takes high-risk patients. Is it your opinion that the Countess of Chester should not have been at a level 2, therefore taking those high-risk babies? Should it have been at a level 1, which it was later downgraded to? And do you think that all that you said about the physicians and doctors who were working on the unit at the time, that those doctors at that unit for a level 2 did not have the appropriate level of qualifications and experience to be able to operate and treat those high-risk patients?
So I'm not familiar with NHS, so I'm going to punt this one over to Nina.
You know what? It's crazy because my friend's saying that how she looked shocked when she got picked up. But we've seen this before. We've seen this before. The toddlers, for instance, that's a good example. I think that's one of the best examples. The toddlers. He was under the care of their foster carers, and they came out and spoke. I mean, he had a mask, fair enough. He was trying not to look a certain way so he didn't look guilty or whatever. He was trying not to pull faces, and she was trying to look as innocent or whatever, whatever. And then later on, it came out that how they had something to do with it. And because they haven't got the remains that they can do the autopsy on, so that they can say, okay, it was blunt force trauma, it was this and that. In this case, yes, there is like descriptive medical papers, right? So he's saying, oh yeah, well, it should come out earlier. Maybe, I don't know, man. I don't think it's so clear cut. I will talk to my daughter because my daughter gives very good predictions. She's like the Mystic Meg in the house. And I'm just like, I don't know. I'm not sure. So anyone who's pregnant, you need to be wary of when your child, keep an eye. I don't know, how are you going to keep an eye on your child when they're in NICU or special babies unit, certain stuff. Maybe you might have to ask them like 1,000 questions. Why does the baby look like this? Why is the baby Why? You might have to ask a lot of those questions, because if it is clear cut as this, where they out of the blue, this comes now and then this clears the stage, clears the air. Oh, you're innocent now. You could come out. Oh, we're gonna create a retrial. You're innocent now. I don't know. My instincts tell me different. I don't know. I mean, my friend's saying because she's young, she's 35. She's talking about Beverly Adlid, I think it is, who also unalive babies. I can't remember the one with the dark hair. Talk about her. I can't remember her name now at this time. I'm just totally blown away. Totally. I just want to see what happens at the retrial. When she gets off, where's she gonna go? I know they're gonna send her to another hospital because she still has her. She still is registered as a nurse. They didn't take her off the register. She's still a registered nurse. So I don't know. What is that saying?
So there are three levels of units, as you know. There are neonatal intensive care units, local neonatal units, and special care baby units. And so levels 1, 2, and 3, or 3, 2, and 1, I should say. And the Countess of Chester was, as you say, a level 2 unit at that time. Now, a level 2 unit operates within certain general guidelines. They will accept babies of a certain category, and they will not accept, or they will try and ensure the delivery of babies who they're not set up to deal with in a tertiary centre. That requires collaboration, cooperation, discussion between obstetric and neonatal teams. So I think the first point I would make is that there is a legitimate question to ask. Did those conversations take place?
Man, that was long. Look at the time. You know what? I gotta come off. For the whole afternoon goes and I don't do that. I might have to come back tomorrow. We might have to finish this tomorrow because, yeah. Please tell me what you think in the comments. I mean, people's gonna say she's innocent anyway. So that what you think. I ain't gonna take that away from you. I feel differently. I don't know. I just feel differently. And I hate when I feel that. I hate when I feel that. I'm one of them. Sometimes my gut says that, and then I go against it. And then later when it comes out that it was that. I'm not just gonna say, yeah, accept this and yeah. No. I'm gonna wait and listen. That's what I'm gonna do, because that's what I do. I wait and listen, and then when something drops, then I listen and I listen and I listen, and I'll make up my own mind. I'm not just gonna take this as whatever, okay? Yeah, and yes, and yes, and yes. Like, I mean, they're saying that the babies might have been located in the wrong places and all sorts of stuff, and I don't know. Maybe I need to go and look at the Countess or whatever Chester Hospital layout to understand what they're talking about. That there was a level 3, 2, and 1. But I'm sure they showed it on the map somewhere. I'm sure. I'm gonna go look at it for myself. I'm not taking just the word for it. Because when you take someone's word for it, it might not be so. All right, you have to go look for yourself, and then you say, okay, fair enough. All right, they messed up. They failed the children. Okay, they failed the children, if that be the case. And the woman, she was innocently, whatever, accused. Me, I'm just going to listen. I ain't going to even, right, I ain't even going to, my gut says differently. But like I said, I leave it to public opinion, because this is what it is now. It's public opinion on this one. We'll deal with this lady's talking about, where the NHS is in the is where they're going to talk about the NHS and all that, because the NHS do have problems going on and certain things going on, and even with dental, there's some, the dentists ain't as great as they used to be. There's a lot of things that is not as great as they used to be. So failing premature children, that's nothing new then, isn't it? But now you're saying that the person who's a serial, you know what, is going to get off. So I'm thinking, okay, she's going to get off. Okay. All right. Minasa, no, Minasa, yes, I'm just gonna watch. But anyways, thank you, Christine. Because I've got to come off. The day's gonna go, and I'm not sitting there till whatever time now and get lost in the sauce. Native and Christine, thanks for coming through. I think I see Ghetto Child. Did I Ghetto Child? Did I see Ghetto Child just now? No, I didn't see Ghetto Child. It is very strange circumstances. Or maybe that was me. So what I'm going to do, I'm going to come back and I'm going to finish the video. And then if I feel, I'm going to ask the ones who deals with babies, I'm going to ask how they feel about this, and ask them to take a look at what the doctor said, and I'll listen to the ones who's in medical positions, who works with babies and stuff like that, whether it be America or England. If that other person comes again, who did a video on them, I'm going to go see, she's made a video on this as well, because she was really good as well. She was very good. Okay, she was very good. If she's making videos, and then I'll see, and then, yeah. So with that said, I'm not going to prolong this any longer. Take up your time. I will see you probably tomorrow, but I don't want to be always online all the time. I'm trying to break up and go watch something else, listen to something else. Channel myself somewhere else, at least. You know what I mean? My mind's somewhere else. Because I've been watching too much of that jazzy stuff. And I feel like I need to get off of it right now and just forget it. Like, forget her. And forget all the other stuff. And deal with this. Like, yeah, because these are children who didn't ask to come into the world, or they probably was planned babies. People probably was trying to get pregnant and couldn't get pregnant, probably kept, there's miscarriages, they finally get their baby, and then this happens. So I'm looking at all that. I'm coming from that angle. Okay. So excuse me if I'm not accepting this. I'm not accepting it. And like if I am proven wrong, okay, I said okay, I'm wrong. I'll take all back what I said. But if I'm proven right, and my gut is telling me that this lady is guilty, because I love how people change their tune real quick. I love how they change their tune real quick. I don't know. I'm just saying. I'm not saying nothing else. I'm just gonna watch. All right, so we'll get back to this probably tomorrow because there's not a lot to finish. But I just don't want to be sitting there till after 1 o'clock when I could be doing washing up. Even though I came on because that little bit what I put on the live yesterday wasn't enough, and I feel that I wanted to hear more, and I wanted to know who the people were sitting on the panel, and I wanted to actually go and look into what he was talking about. Even though, like I said, I get what is and what is, but it's nice to just know and understand exactly what's going on and how it affects babies. What are these symptoms? How drastic are they? How life-threatening they are? Could it have been prevented? See, those questions like that, those are the ones I want to hear. I want to hear answers to that. Could this have been prevented? How could it have been prevented? Right? Was she picked on? Is she the victim? Okay, she's not the victim. So do the parents get anything after this long heartbreak, going to trials, hearing over and over and over and over and over how their children passed away? I don't know. I ain't convinced. But anyways, let me come off and I'll leave it right there. And I'll see you guys in another live probably tomorrow. Oh, I probably might give it a break because after this is so much. I might just give it a break tomorrow. I'm going to try to resist turning on the live tomorrow. I'm going to resist scheduling a live tomorrow. I probably might just record the rest and put it up so you can hear and you lot can tell me what you think. And please go and listen to the playlist of Lucy Letby from when she got arrested, when they found out about her, the whistleblowers, all that. The content creator who actually looked into, I think they looked in about the blood or something. Boy, I'm getting forgetful, man. Look at the playlist. Look at the playlist. Okay? Look at the playlist. And then I'm going to try and see if I can find all what Dr. Lee said and see if I can listen to each one if I can. Listen to each one because, I have a younger one. Sometimes even I'll be like elsewhere. I get distracted myself too, but I try my best. If there's only one thing I can do is put the rest of this up. And that's what I plan to do. Somehow I'll put it up, even if I do it the day after. So, with that said, I'm going to leave it right there. I'm going to leave it right there until tomorrow. And have a great day, Christine and Native. Until the next live, take it easy. Bye.